I'm going to go ahead and start recording.
Clicked on it.
Right.
Okay.
And here,
So
down your speaker, please check your connection or use a different speaker. Oh, that's
okay.
okay.
For those that
I'm off now.
okay.
I still
Just
can't
gonna
get
say.
in. I just hear you. I can't see anything. Just FYI.
It'll be available for you online on our website also.
Okay,
So
that's fine.
let's go ahead and get started. We're really excited to have Joel Conger speak from Connections Health. So Joe is a highly experienced professional, long career, even though you're not that old, but you've had over 30 years in the behavioral health community in Arizona. He holds a position in the Arizona market, leading the organization. I'm just reading from that. Under Joel's leadership, 30,000 Arizonans each year who are facing behavioral health crisis come into contact with Connections Arizona. Before joining Connections, he served as the Associate Vice President of Molina Healthcare. During his tenure, he was pivotal in the procurement of integrating healthcare across multiple states, and his strategic contributions were instrumental in expanding the reach of behavioral health services and ensuring integration for diverse populations. He also has extensive experience in the public sector domain and has just demonstrated leadership and accountability consistent with trying to drive positive change and positive outcomes and improving the lives of those who live with behavioral health challenges. And he's committed to making a difference in the lives of individuals facing behavioral health crisis. One other thing, just so remember, they are a behavioral health provider, so I think they'll be willing to answer general questions. But if you ask, why did my son, get released last week they can't discuss that, but I think they can answer kind of general policies like that. But with that, I'll go ahead and share the presentation. Oops. Let me know when you can see it.
You see it?
Yeah, I got it.
I see it.
Okay, Joel. So it's
right.
Over to you.
Thanks so much, Lori. Those bios are almost so much easier to write than to actually have read back. But yeah, it's great to see some familiar faces.
Yeah, press that. See.
No, that's the
that's what-
microphone.
Oh,
Again, my name is Joel Conger. I'm the market president for Connections Health Solutions. I've had the absolute pleasure of serving Arizona, primarily the central region, going back to 1993, and when I was a case manager for ComCare. So I've had the ability to really watch this system grow and flourish and become a better system. It's far from perfect, but we're working hard to get it to where it needs to be. I joined Connections last October as the market president, and one of the first things that was brought to my attention when I had joined Connections is that we had been selected to open up a CI, court order evaluation pilot program, and that was an agreement between Mercy Care and the county and some other stakeholders. And having been in the system as long as I have, and I will take a moment to call out my dear colleague, Shelley Curran, who is the one who encouraged me to apply to be a case manager back in 1993. So having been very immersed in the system for the longest time, that whole involuntary process was pretty much managed completely by one organization. And that was, if you were going through that court order evaluation and court order treatment assignment, you would go through the Value system. And that system has refined and become incredible. And it has served a great purpose. But the need to expand and potentially take a look at different ways of doing that court ordered evaluation process had never been a thing, at least in my experience. So when I came on board Connections and was informed that we were given the opportunity, we were awarded the opportunity to pilot a program that does that court ordered evaluation process. Needless to say, I was super excited. I came on board in October, and so much work had been done at our UPC facility during the time prior to me joining to actually be able to facilitate this process that included remodeling an entire inpatient unit. We actually built out office space for the Office of the Public Advocates. And we constructed a virtual courtroom, and just all of these things that had never really been in place before. So flash forward to January is when the unit actually opened. And Lori, if you can jump to the next slide, I'll just go over some highlights of.
Can we ask a question though?
Sure,
Or
of
would you rather
course.
have all?
Of
So
course, anytime.
one would say Connections, OGPC, and CBI are screening agencies. Are you? I know the answer, but for those that may not, can you talk about the difference between screening versus court order evaluation and why you made the change? Was it a capacity issue? Were people not able to be evaluated in that 72 hours? Why?
Sure. So, being designated as a screening agency, and I believe there's still three, Shelley, keep me honest here, but there's Connections, and then there's Community Bridges, and then there's Recovery Innovations. And the role of the screening agency is to do just that. Anytime that a petition is applied for someone to be evaluated for involuntary treatment, there is a very prescriptive screening process that has to take place that involves, two psychiatrists evaluating an application to determine if someone is unwilling or unable to receive behavioral health treatment, and if so, that launches the court ordered evaluation process. In terms of why this pilot was started, I believe it was tied directly to capacity, because a lot of times you have folks who are being petitioned for involuntary treatment, and the statute really defines some very specific timeframes for which evaluations have to take place. And depending on the outcomes of those evaluations, then those folks need to be moved to a facility that can actually conduct that court-ordered evaluation. And what was happening, and unfortunately is still happening, is that due to the volume of folks that are going through that involuntary process, there were times where, due to capacity and not having the beds, for lack of a better way to describe it, to facilitate this process, folks' petitions were actually timing out. And what that meant is that, if we were not able to complete our role and get folks assigned to a designated facility within that 72-hour time frame, folks would either have to be repetitioned, which would kind of restart the whole process, or in some instances, folks, we no longer, as that screening agency, would be allowed to hold them against their, we'd be violating their rights. So it was a culmination, I think, of a lot of things where the system needed to see if we added capacity, if it would make a difference. And so, while Valleywise has hundreds of beds, to facilitate this process, the volume of folks needing to be evaluated sometimes would exceed the number of beds that were available. So while this is a very, very small pilot, and we were awarded the opportunity to open 16 additional beds that were actually connected to our screening process and our entire continuum. The idea was to explore, if we add these additional capacity, will the system benefit from it, and will things continue to get better? And in my biased opinion, and actually in just straight out objective data, I can say that yes, we do add additional value to that system, to that process. And before I jump into kind of all of the stuff that gets me really excited, I want to make sure, did I answer your question?
I think so. My other question related to that is, are we seeing more people in need of psychiatric screening? Is it hundreds? Is it thousands? Is it the fact that Maricopa is now growing rapidly as a big city? Is that adding to it? Is this enough? Do we have hundreds or do we have thousands of screenings a month in
Well,
the whole system?
that's more of a system question. I mean, I can certainly tell you from a provider perspective, we are seeing a significant amount of folks come through our doors. There was a point in time, and certainly people were not all in there involuntary, but we in our facilities we offer multiple lines of service, and the primary one related to the court-ordered evaluation process is our observation unit. And in Phoenix, we have 50 what we call recliners, and in Tucson we have 25. And so at any given time, probably 60 to 70% that are in our OBS unit are there on an involuntary evaluation. So a couple of probably 3 weeks ago, our OBS census actually hit 70. So we were bursting at the seams with folks who needed to be who needed to receive that evaluation and potentially that subsequent treatment. So, again, we're just one part of the puzzle there, but as a system, I could extrapolate very easily that, yeah, we need additional capacity. We absolutely do. And, there are some challenges to getting there. But I'll talk about that in the next slide, but in what we're experiencing, 100%, yes, I would say there is need for additional capacity so that we can prevent, number one, from violating people's rights, number two, keeping those petitions from timing out, and then making sure that we have a smooth continuum of care. And Maricopa County has grown significantly. Yeah. And the good and the bad of that is there are, a long time ago when I started in this system, we were pretty limited in the overall number of behavioral health beds. But in the past, 6-7 years, I've watched that explode to where I think now we've probably got 1,000 adult, inpatient beds, but there are only a very, very few beds that are designated to treat folks who are either on that court-ordered treatment or to go through that process. So the corresponding growth in inpatient bed capacity is there, but the corresponding growth for this incredibly important, process to help folks who are struggling and may not be able to recognize that they need help, or they're just not willing to accept it. I think we've got some significant opportunity to grow that capacity.
Thank you.
Did that help, Lori? Did that answer?
That did. I know Rachel has a question which is probably more aimed towards Shelley on is Valley-wise adding beds. I know from Dr. Olson that part of their challenge with the beds they already have is staffing. They haven't been able to open like a whole bunch of beds because they can't get enough staff that work consistently. So there is capacity if the staffing levels improve. Shelley, if you want to add anything, I just know that from Dr. Olson.
Hi. Yes, staffing is certainly an issue at Valleywise. I'm going to put some information here in the chat. This is just our stats from yesterday. We had 82 people across the crisis facilities, connections, recovery innovations, community bridges that had come in. They might have come in on an emergency admission. They might have come in on a non-emergency PAD, but the court had ordered a 72-hour evaluation for them. And the crisis facilities had determined this is not somebody that we can convert to voluntary. We believe that this person needs to continue through to a COT hearing. They were on the list to transfer to Valleywise. The packets were sent over to Valleywise. Valleywise was able to admit 10 people yesterday. I know they had 3 units on quarantine for COVID yesterday. So it's not that Valleywise isn't trying. It's just that they don't have room. And one of the reasons why we wanted to start this pilot, and the pilot was funded through a joint effort between Maricopa County through their ARPA funding, their COVID funding essentially, and through Mercy Care, to allow these virtual court hearings, to allow the court process to take place at Connections, to try to alleviate some of this backlog. So yes, staffing certainly is an issue. I know Valleywise is working on it. I know that the county has provided additional funding to Valleywise to recruit and retain staff, especially nursing staff. But it's a real struggle right now to be able to get somebody through the whole process who really needs it.
Yeah. Thank you, Shelley.
This is Evelyn. I have a question. When you talked about adding 14 beds, are those hospital beds or evaluation beds?
For Connections, it was 16, and they are inpatient beds. So they are hospital beds.
Hospital
We made it
beds.
very clear from the beginning, no COEs and chairs.
Yeah.
It has to be a hospital bed. And so I think that was my mantra when we started.
Well, thank you for
Any
that
other questions?
impression.
And thanks, Shelley, for providing that additional content. I actually on the next slide, I went back and looked at, I think, the last, I don't know, 15 to 20 days, just so folks can understand the activity that's happening in the system as it relates to people who are awaiting going through that legal process. And we'll get to that on the lessons learned slide, but just some things that we've experienced. I believe we took our first patient on January 19th. And since that time, we've had 207 folks come through. Again, we're only a 16-bed unit, so it seems like a small number, but it's huge. And we were at any given time we're 96%, 97%. I think this 95.2% metric that I'm presenting here is probably a little conservative. Because our unit it is rare that we are not at 16 beds full. So just in terms of our approach, I'm super proud of our multidisciplinary. We've got the providers, we've got the nurses, we've got the behavioral health techs, and we also have recovery support specialists, which is that peer support element. And so anyone and everyone who comes through the doors of our facility, regardless of their voluntary or involuntary, they get that full array of service. And through of the 207 folks that came through the engagement and helping educate folks and really understanding where they're coming from and what they may need, we were able to encourage 16% of the folks who are coming through to actually accept voluntary treatment and to make sure that they understood what accepting voluntary treatment, entailed. And by way of that, we were able to, keep a number of these folks their ability to make their own decisions as it relates to their treatment. And I think that's really a dedication or a testament to our approach and the way we work with folks. I think one of the other amazing things about the Connections pilot opportunity is that as people coming in through that initial COE process, and we determine that, yeah, you know what, you do meet criteria and we need to carry this through. By virtue of the fact that it all happens in the same facility, we're able to maintain that continuity of care so that, we know what Joel looks like on day 1. And then at day 4 and day 5, we know what Joel looks like. So it's not, having to, okay, yep, you met the criteria for this. Now we need to find another place for you to go to complete the legal process and to get folks started on treatment. So, and again, it makes a difference. It truly does. That continuity of care is huge. One of the most outstanding things that we're still grappling on making sure that we're measuring things correctly. If we look at everyone who's come onto our unit, so whether that's folks who go through the entire process, or that they agree to voluntary treatment, or that we've determined that they don't meet criteria for involuntary treatment, that average length of stay is just under 14 days. The average length of stay for the entire process to play out, and we removed a couple of outliers, right? Because we had someone who we had to relocate to a different country, and they were with us for 50 some odd days. So we had to make sure that the data was reflecting a majority of what we were seeing. And, if we remove those outliers, our average length of stay for this entire process is about 16 days. And if, comparing this to the current process at Valleywise, you're looking at anywhere between 19 to 21 days. So we're able to based on the way that we're operating this pilot, we're able to do it in an efficient manner that gets folks through the process and gets them treated, and then gets them connected with the outpatient supports that they need in a fairly significant shorter amount of time, especially when you think of what it's like to be in a hospital for one day. Moving that from 21 to 16, it makes a huge difference.
I have a question.
Sure, James.
This is Mike Franzak.
Hey, Mike.
Hi, Joel. Yeah, I invited your fan club to attend, Joel, but I don't know. But anyway,
is that the only member is you, Mike?
No, there's a whole bunch. But anyway, are you an IMD?
No, we're not.
You're not an IMD. Okay, thanks.
No, we're not connected to. Although we're in an old hospital building, we are not connected to a medical facility.
But your bed size was 7. Did you say it was 17 or what?
16.
16. Okay. So, okay. Thanks.
Yep, you bet. Good to hear from you, bud.
Joe, my question is has to do with your exercise of convincing people to take voluntary treatment, which is a great idea. I just wonder whether or not you keep track of those patients when you send them out for voluntary treatment, and to determine whether or not they followed through with voluntary treatment. And secondly, do you keep any statistics on how many come back?
Yeah, that's a fantastic question. To make sure that folks do get connected, that's absolutely part of that coordination of care process, to make sure that they have that appointment scheduled. And, are we 100% in lockstep with making sure that they attended that appointment? We've got opportunities to do better there. But absolutely, that is part of our process, is to make sure that, if someone's already, if they're designated as someone with a serious mental illness and they're already assigned to a provider, we're going to coordinate with that provider. If there's someone who has newly been determined as having a serious mental illness, then we're going to coordinate to make sure that that provider knows that Joel's been, I've gone through this process and I've been referred, and they need to get me in within that 7 days. Now, the readmission component of your question, Jim, it's a challenge. I can only tell you if Joel came to the Connections facility and I came back, I can tell you that. But what I can't tell you, because I don't have visibility into the system, is that if Joel came to Connections and then a week later I got petitioned and I went to RI or I went to Community Bridges, I don't have any visibility into that. So I can't give you a comprehensive question or answer to your question. I can tell you that, and this actually looks across all lines of business. If I look at just Connections readmissions, it's typically between 4 and 5% of people who come to see us will return to us within 30 days. I cannot, right now I don't have the data to go in and analyze and give you an answer as it relates to the folks who have been through the COE process and we've converted to voluntary. But that's something that I could certainly take away to look at.
I wonder if, Joel, with following up on that, maybe you can't, but Mercy Care for at least Central Arizona could be able to see if it's a perfect example, like same for my son, who's stable and doing very well, but in the day, he would agree to anything to get out of a screening agency or court order. He would, of course, on voluntary, but when you've seen them 8 times, when do you decide that we can't trust that they're able to stay voluntary? Do they get flagged in the system at some point?
Are you asking? I mean, are you asking from a REBA perspective, or
Even from your agency, but I think from REBA, if you have someone that keeps going in and out and in and out, and they keep saying they're voluntary, but they really fail to participate in their treatment, at what point do you want to save their brain and say, I know you say you're voluntary, but
yeah, and I can tell you we do know who our familiar faces are. And that does weigh into your decision. If Joel shows up on 4 petitions in 5 weeks, you know what? Maybe it's time to look at this a little bit differently. And I can't speak to how Mercy, but I know that they do evaluate familiar faces in a number of different facilities. So I'll let Shelley respond from a system perspective.
Hi, Lori. Yeah, for the familiar faces, we do notify the behavioral health homes when somebody that is enrolled with their care is a familiar face at crisis facilities, regardless whether it's voluntary or involuntary, and do expect them to follow up with those members because of their frequent crisis utilization. We don't have a way right now to track familiar faces based on voluntary versus involuntary. We track familiar faces, and that's across all of the crisis facilities. So the Connections, the Community Bridges, the Recovery Innovations. The group that we do track by individual are those that we're not able to get over to Valleywise because there's not a bed. They don't exhibit petitionable behaviors while they're on the unit, so they can't be repetitioned. A new petition can't be filed. We call these people timed out. So these are the people that the crisis facility, all the way up until the very end, think they really need to be on COT. We need to get them over to Valleywise, and Valleywise says, we don't have a bed, we don't have a bed, we don't have a bed. 72 hours are up. For those folks, we do track on an individual basis. Where are they? How are we engaging them? Are they repetitioned? Are they engaged? What do we need to do to bring them into care? That's the population right now where we are just laser focused on. are those that really needed to go through the process but couldn't based on capacity. The others is familiar faces just based on crisis utilization, not specific to voluntary or involuntary.
Yeah, this is Mike Franzak. From the provider level, we get data from Mercy Care showing people who are readmitted within 30 or 90 days. And, Joel wouldn't know if they went to Aurora or Copper Springs or wherever. But at the health home level, we get monthly data on the readmission rate, which generally across the system seems to be running in the mid-20s, which is pretty high. But again, it's not the people that just became voluntary. We don't have that either.
So 20% or 20 people?
Oh, it's in the 20% category, more than 20, maybe 22, 23%. Some of that is due to social determinants, or what they're now called health-related social needs. Some individuals who are homeless are choosing hospitalization to being in 110 degrees. So you really can't, blame them for survival activities. So it's higher in the summer, but it's bigger than the crisis system. It's the entire inpatient system that's getting readmissions.
Yeah, I think, Lori, the CMS target, and it's been a minute since I've been on the payer side, but for 30-day readmissions, I want to say the threshold that they established was either 13 or 14%, and that plans that received Medicaid dollars, that's what their expectation was, that their readmission rates were below that. Now there's a whole new wrinkle in readmissions that I could spend another hour on talking about, and the way that it's being measured now is called all cause readmissions. So I could have had an episode where I was feeling pretty depressed and ended up in the hospital, and then the following week, I could have sprained my ankle and ended up in the hospital, and that would count as a readmission. So it's a little more challenging and aggressive to manage those, that process. But I can tell you that the plans are working hard to do it. It's a challenge, though.
So Rachel has a question.
Hey guys, and I want to preface that this is an emotional topic, and a lot of the folks that are joining today have had frustration and significant impacts to their family as a result of a petition happening and a loved one not getting a bed, not getting treatment. That said, you guys have such a vital role in our community. Thank you for coming here and doing this. One concern that I have is that in the process, the family will get a call from someone if their loved one gets to Valleywise. The petitioner, usually it's a parent family member, there will be like a family interview when they get to Valleywise for COT. And to me, that's late in the process. The petition, and they're at the COE center, they're at CBI, they're at your facility, or they're over at our, right? Why can't that family interview happen sooner during the evaluation? Because there is vital information that the family has about these individuals. There are people who would still be alive today if the COE center had asked a caregiver the right question. And that's the devastating gap for many of the families that are here on this, is that we got the petition approved, our kid's finally going to get help, but then they're released often with devastating consequences. And maybe they didn't, you know, display the right level of danger, but no one asked us. You had the petition. I mean, there's a lot of, you know, why can't that family interview happen sooner? That's my concern. So I'll
And
stop.
I think Rachel, in addition to that, I don't know about all of your experiences, but in my experience, our loved one was not a great historian. Did not want to
Right.
tell,
Yeah.
did not want to tell the same story. And I mean, do you want to replay something that you may have said that you didn't say? But imagine them. Do they want to really report embarrassing, troubling behaviors? So I think it's even more important to get someone that isn't in psychosis to be able to tell the history to the clinicians that are observing someone on their best behavior. This is the best you're going to see them, right?
Yeah. Yeah, and Rachel, that's that's a tough question, and the last thing I want to do is sound like I'm giving you a canned response. I can tell you that part of that entire process involves seeking that collateral feedback and understanding, who's involved in this process, who do we need to talk to, because all of that goes into the formula. It should go into the formulation of what's going to take place. I can tell you, and I think Clay is on. He oversees the clinical operations at the UPC, but that is one of the most significant yet challenging processes we face every single day, is being able to, number one, identify. I mean, obviously, if we have the petitioner, we're going to do that outreach. But it's then working with a person and trying to understand, hey, who can we talk to understand more about what's going on with you? Who's your supports? Who can we engage? And that is something that historically the system has struggled to do, and I'm watching it firsthand. Under my auspices, and I'm working with our clinical leadership. We've got we just promoted our she was the medical director of UPC, but now she's our Arizona medical director. And that's one of her key tasks, is to make sure that, this collateral information is being collected and it's meaningful, and that we're actually going in and we're reconciling medication and doing all of the things that really would, if done 100% all the time, will absolutely make a difference in that.
Who is that
and
that you're
we've got,
referring to?
Teresa Costales.
Just calls. Okay. So I've gotten calls from her. And your facility is doing better at this. Other facilities, absolutely tragic gap in care. To not
I'm sorry.
contact,
I'm glad to hear that.
Yeah.
We're doing better. But I can tell you, we've got a long way to go.
Yeah.
And I own that, and I recognize that. And
I don't envy your position, but thank you for doing it.
Linda, you have a question?
Yes, I'm a guest here, and I'm from California. And I did see, Joel, that you used to work in California for Molina.
I worked with their plan. Yeah.
Yeah, you work with their plan. I just want to say that we have the same issue here in California, where families are supposed to, by a law, be able to give information into facilities that have our loved ones in there. But as I found out, there's a loophole in that law. And I mean, I took a hospital all the way up to the state insurance commissioner and everything else. And then I learned that there was a loophole, yet all of the NAMI chapters have an actual form that they give to parents to fill out, so they're prepared. So what I'm getting at is, I think it's pivotal that in order to get all the information needed to make the decisions, including the family input and the medical history, there have to be consequences for not following through with that. And when there are no consequences, then things are left and people are let out because they present well and have a plan of going out and living under a tree in Seaport Village, which happened today with somebody I've been working with, and that's why I'm late. And this is incredibly frustrating. So I'm just throwing that out there. I know a little bit about your system in Arizona because I know Lori and I know Rachel. But in our state, it's happening too, maybe in a different way. And this is something we really, really need to work on across the country. And now I'll be quiet.
No, Linda, thank you for that. And you're 100% right. You know, I was running an SMI clinic when HIPAA was introduced, and the different machinations of interpretations and all of the things, you know, folks were left trying to figure out, well, hey, am I going to get fined? Am I going to go to jail, or can I do can I do what I need to do? And it's taken years, and again, something that we're not there yet, but we're making strides.
And that's something too about the HIPAA is that I did some research on that, and I found out that the number of doctors in the behavioral healthcare system that had been brought forth in suits because they violated HIPAA was zip. So in HIPAA, in the regular healthcare system, is carried out differently than in the behavioral healthcare system. And in the behavioral healthcare system, it seems like they have terrorized the doctors and clinicians into giving out any information, which is nuts because when my mother had dementia, I could find out information from her doctors. But when my loved one was in the hospital in psychosis, I could find out nothing. Just throwing that out there.
No, and I wish I could tell you something that was new and exciting and that was gonna, make a change. But we're just continuing to educate our staff, and to educate families and to try and cross that bridge, because that connection and that resource, as fragmented and fractured as it can be at times, is invaluable to really helping folks achieve that recovery. So we've got a long ways to go.
But with HIPAA also, like Chuck said, in the ER and emergency room, if someone is crashing, if someone is brought in unconscious, if someone can't speak for themselves because they're incapacitated, that goes out the window. They are talking and asking and everything else. They just treat it differently when it involves the brain. I mean, if you have a head trauma, they won't. And sometimes I think it's not all, but some people hide behind HIPAA because they don't want to deal with the families because we can be a pain. We're demanding. we don't want them to release people that aren't going to follow through. So I get it, but
I think there's that lack of education. There's that fear. There's a lot of things that come into that equation. So
I recently learned that in 2016, Arizona passed legislation clarifying HIPAA policy. And the privacy policy is actually very clear. Even if your loved one says, no, don't talk to my family. I'm not signing an ROI. You can't talk to my parents. Even if there is a case, and it even spells it out, temporary psychosis or intoxication, if it's in the patient's best interest, you can provide necessary information to the family. That is spelled out in the HIPAA privacy policy. I'm happy to put it in the chat, but that's very clear in the patient's best interest. And Arizona statute took time, passed a bill in 2016, clarifying that and spelling it out. I have yet to find a facility actually following that. And we're going to propose more legislation. Let's just put it that way. But again, it's misunderstood everywhere.
Yeah.
I'll shut up.
you're fine.
So Jill, you have a question? You're on mute.
Sorry, I'm just going to add that one way around this is to be guardian. And I have had a pretty good response to doctors speaking with me and accepting and listening to information. However, it's not so easy being guardian. And it's also, for a lot of people, it's very costly. It involves a lot of work all the time. So that's probably the best way to interact with the doctors, but I'm just saying it can be very challenging also to be guardian, to share. I don't know if you would agree with that, Lori, but There's
Yeah,
a lot of
I think,
documentation that
yeah.
has to be done, everything, yeah.
It's no parent's dream, at least not my dream, to be anyone's guardian for any longer than necessary, ever. I mean, you want your children and family members and others to grow up and go on. I want them to be my guardian. I don't want to make any more decisions. I think that I think it's misrepresented sometimes in the press and in the news that people are trying so hard. You do it because you must do it, because you
Yes,
care about someone. Yeah.
I think it makes a
Evelyn,
big,
do you have a comment? Yeah, I do too.
Oh, yeah. Two questions. One, I'm wondering, does Mercy Care talked about tracking the frequent flyers? Do they also track the non-Title 19 patients?
That would be Shelley.
Yes, yeah. Hi, Shelley with Mercy Care. Yes, we do. In regards to the people that hit the crisis system, that is our responsibility. They have a crisis enrollment. And if they are if they have the SMI designation and they're non-titled, same thing. We do track those familiar faces and we notify their health homes and we look to see what's happening with that person. Just as Dr. Franzak had shared, we share that with his teams, not just for the Title 19 folks, but for anybody that is connected to COPA.
Okay, and my other question has to do with the hearing for the COT. When my family member was going to go through that, the county prosecutor informed me that we need 2 witnesses, and it could not include the doctor who actually wrote the petition in the hospital. And they thought that the social worker that was working with the patient in the hospital would be one of the witnesses. And in the end, either she decided or the hospital she was working for decided that she couldn't do that. It would be a, quote, conflict of interest. And so we almost had to lose the hearing because I was one witness, but then I had to try and call around and find a housing provider that he had been at that was willing to be the other witness. Is that a common thing that hospital staff cannot be a witness?
It depends. I know that there was a Court of Appeals decision. I don't have it off the top of my head. Not too long ago, that if somebody is treating a patient and they don't disclose that information that is shared with them, that would normally be treated as privilege, if they don't share with them that this is, part of a process that could eventually go to court, then the Office of the Public Advocate has been able to have those cases dismissed. And I know that the county attorney is a bit leery of having somebody as a witness that hasn't made that disclosure to the patient in a way that it's documented so that the Office of Public Advocate could know. So that's one of the issues. The other issue is that if hospital staff just say, we don't have time, we don't have time for this person to go down and spend, 3 hours to testify. That's another issue. So it depends on exactly what happened in that situation. It does come up. I don't think it does come up as often. I think when Office of Public Advocate first started to bring this up, went up to the Court of Appeals, started saying that you can't have a clinician who the patient thinks is in a privileged conversation, then come and testify. That was something that was playing out. It was in the middle of COVID. I remember everyone was working home at that time. I haven't heard of it happening as much lately, but that is something that comes up. So it's always best to try to get as many lay witnesses as you can, so that you don't run into that issue. But
well,
yeah, it does happen.
Maybe you need to better educate your hospital staff that they need to let these patients know. Mm-hmm. And give them notice so that they can.
Yeah, agreed. Agreed.
I mean, they're the best ones who see the psychosis when they're in the hospital.
Yeah, and at Valley Wise, they understand that, and at the crisis facilities, they do. At some of the private hospitals, not so much. So, or the medical hospitals, right, on the medical units. So, I agree. That is a big training issue.
Well, this was at
Okay.
a behavioral health hospital, but it wasn't Valley Wise.
Yeah.
Hey, Lori, I want to be a respectful
Cognizant, I know.
time.
I know.
Yeah,
I know.
I did just some of the lessons learned that I wanted to share with this group. You know, we're 7 months in. And to your question right out of the gate, Lori, the capacity is still a challenge. And to Shelley's point, where she talked about yesterday, there were 80, you know, over 80 folks waiting for a bed to go through this process. I went back and I looked at like I think it was the last 20 days of Mercy Care sends a very detailed crisis report out. And what I want to you know, call attention to is as we look at the Valley-wide system and you know, how we've got to, if someone can come up with a staffing solution, that would be like the greatest thing in the world. But it's hard. But if you look at the purple line, that shows how many folks on a daily basis are waiting to be transferred over to Valley-wise to go through the process. That Connections is one of 3 contributors to that purple line. The light blue line looks at how many discharges Valley-wise is able to do on a daily basis. So you can see there's just a clear disproportion of how many people need this service relative to you know, that throughput that's happening at Valley-wise with the I want to say they have 400 beds. Shelley, you'll keep me honest there. But at any given time, due to staffing and other challenges, they're just not able to keep those open. And then on the last little data point I included there was just the number of units on any given day that are shut down due to quarantine. So I think this just really paints a picture of the need for additional capacity. Wanted to can you explain the legend in the graph? Sure. So the first the gold bars at the bottom here are the number of units that Valley-wise has identified on any given day. And thank you, Lori. I'm sitting here moving my mouse like you guys can see it. Is how many units are
There
on
we go.
quarantine. So that significantly limits the amount of you know, folks that we can the system can move through. The purple line on top is on this measures every between the 3 crisis facilities, how many people have been identified that need to move over to Valley-wise. So you can see it's been as high as 100 you know, on any given day. And then the light blue line, this is kind of what I use to gauge throughput. So this is how many people are being discharged from Valley-wise that are then creating an opening, a bed that we can move one of these folks in the purple over. So I just really think it paints a very, very clear picture that the system needs additional capacity. And you know, just kind of setting the stage, you know, for where we need to go.
Yeah, it's a negative slope of people getting out. So therefore,
it really is.
Yeah.
And it's a challenge. So, you know, I think if you can shrink it back down so I can see my thoughts, because they're all over the place right now. You know, so the impact of this are, you know, we covered it. It's those petitions timing out. You know, we have people who are staying in a 72-hour unit, or you know, for significantly longer and having to go through this repetitioning process. it's huge. So, you know, in terms of the future state for what Connections is doing, right now, our pilot is we're set to be in place through June 30th of 2024, at which point we're going to have to, you know, with all of the key stakeholders, make a decision. Is this something that we want to continue to use to help address some of the capacity issues? And some of the challenges that have been presented related to, you know, keeping an additional pilot program, or hopefully one day a true program like ours up and running, is the way that we do the hearings at Connections. It's virtual. So we've built a virtual courtroom. So folks come in, they have their public defender with them, and they're able to talk to the judge and you know, any witnesses virtually. And the Office of Public Advocacy feels very, very strongly that that opportunity should be able to play out in person. So there's some concern about the virtual modality of that process, which, you know, could impact our ability to continue to operate. And some other kind of confounding factors there are the county has utilized considerable dollars and built I believe it's 2 in-person courtrooms in the new Valleywise facility, but again, due to staffing and all the things, we haven't been able to open those up to this process. And so you know, with that kind of conundrum and you know, perspective of wanting to make sure that we're maintaining everyone's rights and we're respecting everyone and giving them full due process, we've got a lot to kind of ferret out as it you know, relates to enhancing capacity in the system. And with that, that's, you know, just kind of our observations. I think, I'm going to be unabashed. I think Connections is doing a great job with this process. I think we are demonstrating that it can be done differently and it can be done effectively. But we just gotta, you know, we gotta continue to work with the system to help kind of to move these things along. And we need to solve the staffing challenges with you know, bringing the folks in to do this work. That is probably the most challenging work I've ever seen in any field that I've done, watching, you know, the folks come into our facilities and work 12-hour shifts day in and day out with folks who are at their worst, and helping make their day a little bit better. It's nothing short of breathtaking, but we got to do better. And with that, those are my slides. Happy to answer anyone else, you know, questions. But I just, you know, Lori, thank you for the opportunity to present and talk a little bit about the work Connections is doing. I really appreciate it.
I think that you can tell by the response that there's such a desire to understand our system, and also, as Rachel pointed out too, on how we can help provide support so this can keep going and expand. Is Governor Hobbs aware of this? And maybe that's better for Shelley or from you. How do we make sure that our crisis is being addressed with enough funds?
I without hesitation, Shelley Curran has been the biggest advocate for helping you know, recognize this capacity. And I know that they are working tirelessly with their stakeholders to help continue to ensure this type of opportunity continues and grows. In terms of who they're working with, I don't know. That's secret sauce that I'll let Shelley answer that question.
Yeah, we certainly do recognize this as an issue. You know, on any given month, there's, you know, around 100 people who really needed to get to Valleywise and don't. And it's disconcerting. And Valleywise, you know, they're saying that in May they're going to be able to open a bunch more units. How are they going to staff those? I don't know. We would really like to be able to continue this pilot here at Connections, as well as make it permanent. We would like to be able to have this type of opportunity at the other crisis facilities, which is what happens throughout the state. But in Maricopa County, it's just a different, it's just a different animal. The courtrooms are all built at Valleywise. All the staff, the court staff is at Valleywise. So it's conversations that, that we're having with the county to try to figure out, what we need to do to meet this need in our community, this expanding need in our community. In other places throughout the state, the virtual hearings is just a part of the course, but not here. So that's right now our biggest barrier really is that virtual hearing, and making sure that members at, or patients at Connections have the exact same opportunity to face the judge, to face the prosecutor that they would if they transferred to Valleywise. So that's something we're trying to figure out right now. I was just so extremely excited to be able to even have the pilot start in the first place. This is something that has been that I've been working on for 3 REBAs, trying to be able to have expanded capacity. So finally, we at least have the pilot. I think we're showing good results. I haven't heard from anybody that's involved that clinically that care at Connections is any less or any different than at Valleywise. It really is working to figure out how we bring the court system into the process on a permanent basis, as opposed to a Band-Aid that was developed during COVID.
Does Connections, do they have psychiatrists like they do at, or are you using mostly nurse practitioners, or a combination?
We have a combination.
Okay.
Do you have 2 psychiatrists to evaluate the patient?
Yes. And at the Phoenix campus, absolutely.
Now, Crystal has had her hand up for a long time. So after Jim's question, we go to Crystal.
I was just going to say, Shelley, if you, I'm sure everybody would like to see this pilot project continue. If you can kind of make a list of what you think is needed to keep that going, and share it with us at Acme, I'm sure we would try to do everything we could to help you.
Oh, I appreciate that. I do very much appreciate that, and we will. We're talking to our lobbyist right now to try to figure out the best way to keep this going.
Okay.
Shelley, Mike Franzak, it is not just the evaluation process, it's the place to go after the evaluation is done. There seems to be a major shortage in where people would go, right?
Well, to continue the what they're doing at Connections, which is very tiny, as Joel said, compared to the larger system. This was intended to be a proof of concept, right? Can the COE process, taking someone from that 72-hour COE to the petition for court-ordered treatment, all the way through that COT hearing without having them transfer from one place to another, without having to worry about capacity to get them to the next place to go to that COT hearing. That is what this pilot was developed for, and I do believe that the proof of concept is there. We've shown that it's possible to do this outside of Valleywise. Trust me, Valleywise gets plenty of referrals. We would send them everybody if we could, but they can't take everybody. I think the problem with continuing this truly is looking at the court staff that needs to be available in order to support this at Connections, and looking at what's happening with virtual hearings, and making sure that people don't get different treatment if they go to Valleywise as opposed to if they're at Connections. I think that's the biggest stumbling point right now. For Valleywise and for Connections, there's certainly an issue of what's the next step. So they've gone all the way through the process. They've been placed on a court order for treatment for a year, inpatient, outpatient combined. They need to go what's their next step? I think that's an issue for both, but in regards to continuing this pilot or this COE COT program at connections. That really is looking at what we need to do to be able to make this permanent.
Sounds like a great program.
Yeah. Crystal, who is a psych nurse, I'm interested in your thoughts because she's worked at many state hospital here and many psychiatric hospitals.
Yeah, actually, my question also was for Shelley. I was first of all wondering, why are they? Tell me about the quarantining of units with COVID still, because we're not really doing that in the private hospitals.
I agree. And these are conversations we've had with Valleywise. I'm last year in May, they were quarantining units for the flu. So they just have a different, a different way of operating. They're very concerned, and I understand their concern that these are involuntary patients. We don't want to put them at risk. So they are continuing to quarantine. I don't think they're going to move off of that. But it does continue to, decreased capacity in our system. But, we have had those conversations. I understand where they're coming from, in regards to not wanting to put someone who's involuntary at risk. But, in our community, people are exposed to COVID every day. So,
yeah. And, also in the private hospitals, again, like they encourage the mask for the person, or they have the person stay in the room, but it doesn't mean you have to quarantine the whole unit. So, probably should, again, all of us are working around coronavirus now, probably should, move past that. The other question I had was when it comes to the, like the tracking with Mercy Care, sorry, my daughter's wandering in the back. So after you call the crisis team, you say you track people. What are you tracking just to make sure they like go to a hospital, get evaluated, and decide what they need? And then are you done tracking, or what does that kind of look like?
Yeah, it depends on what point of the crisis system they touched, and whether they're a Mercy Care member or whether they're enrolled, say, with United or is on a Complete Health, right? Because we've got 5 different health plans here in the central region, or whether they're with a private plan. So it really depends on what part of the crisis system they touch. All of our crisis providers are required to notify that person's health plan within 24 hours that person had interaction with the crisis system, whether it be crisis phones or a mobile team or a facility. And then it's up to that health plan to make sure that there's follow-up from that crisis episode. For the people who are not connected to any health plan, any access health plan, then what we do on the Mercy Care end for people who had our crisis system is, as Joel was saying, as Dr. Franzek was saying, is we look at those familiar faces. Who's hit the crisis system more than 3 times in 1 month? Who continues to hit the crisis system? Obviously, their needs aren't being met. Their situation is not being stabilized. So what do we need to do to send out a crisis navigator? What do we need to do to work with, if it's a first responder that keeps bringing this person in? So we don't follow up for every single person that hits the crisis system, but we do follow up for Mercy Care members. And for those who are not connected to any health plan or any access health plan and continue to come into the system. So the familiar faces is what we call them.
Okay. So, I guess I have a little bit of a concern with that I just want to speak out about is, so what if they, again, my husband was murdered, and it didn't take that long after the crisis. So I guess I have a little concern about, that follow-up. And again, he was somebody that we tried to get insurance, but he was too paranoid to agree to the assessment over the phone.
Yeah.
So that tracking may not be enough. And maybe he fell through the cracks because he didn't have a plan. I don't know, but
I'm sorry to hear that. And I know that there's certainly lots of room for improvement. Absolutely.
Yeah, it's when they're I would just recommend not waiting a whole month, maybe following up. And I don't even know how do you follow up? So let's say they do go to a hospital, because he did go to a hospital like 2 or 3 times. So what happens then if he's been in a hospital 2 or 3 times, not a member? How do you follow up? is the next question.
Yeah, and that's a whole different concern with who's the payer, who's responsible. What's the contract with the hospital like for the hospital to follow up? What's the contract with the crisis facility for the crisis facility to follow up? You know, with our crisis providers, we do have a requirement that they follow up within 72 hours to make sure the situation has continued to be stabilized. But if they transfer that person to a hospital, then that crisis system hands off that responsibility then to the hospital. So you're right. That is, you know, hospital discharges, especially if someone's not enrolled with our health plan, that's not something we would even have sight on. You know, at Mercy Care, if someone is admitted under their private insurance or, you know, admitted through a hospital, not through Mercy Care, I wouldn't even know when they
Right.
were
So that's definitely a hole in the system.
Yeah.
Because because there wouldn't be any follow-up if the hospital discharged, even if CBI discharged and then another hospital discharged, and it would look like.
Yeah.
So
I think the real tragedy here is, as a psych nurse, you saw this in your loved one at that age of 20, you know, where they're 2021, where they're a full adult. And you were telling the agencies and the hospitals that he was really psychotic and not stable.
Right.
And her ex-husband was a healthcare worker also, but he kept getting released from hospitals, and he just got released from a psychiatric facility, a screening, and then he ends up murdering his father. So now he gets to go
to jail
and spend the rest of his life, and he's in jail, which has been a horrible experience. So it's failures on so many systems.
Well, and again, the part that we were talking about that Rachel brought up, that is part of all of that, is that it should be, you know, out of all the 3 or 4 hospitals, besides the crisis team that came out, all of the CBI, all of the first time he was petitioned at UPC, all of those, not a single person would consider what I had to say or even ask me or anything, even though I said things. So it really does have to do with that family, acknowledging that family for feeling threatened by their own child, that their delusion has to do with them. And that, again, you're putting the family at risk. You're putting the family at risk for domestic violence and the family. And it's just not, it's not right to, when you have an 18-year-old that you don't have guardianship of yet, that you're just going to release them to the family to, again, risk our lives.
Yeah.
So
Totally.
it's definitely a big hole that I ran into. And so that's one of the things we're kind of trying to see if we can make better known, you know, that the family needs to be part of the system. And Mercy Care is just as guilty of everybody else as not wanting to listen. You know, you call Mercy Care and it's like, you're not the guardian, so I can't talk to you. Well, you can listen.
Yeah.
So
That's going to take a systems analysis and probably legislation.
I think it's going to have to be forced, because everybody's been saying the same thing for 3 years. And it just, I just want to pull every single piece of my hair out that, we're going to get better at it. We're working on it. I know it's not. Well,
and without accountability across the system, nothing will change. I've come to believe that really in California, without the accountability, without the consequences, when people across the system let sick people out and put the public and the families at risk, nothing's going to change, in my opinion.
I watched it firsthand. I decided to do intake at my facility. And this is also to Mercy Care. And again, I looked at the, because I don't do intake for this reason, I'm too emotionally involved, but the very last criteria is if a person's psychotic or having bizarre behavior. So one person comes in, they're detoxing from fentanyl, they're, have enough with them that they can get their hair dyed, their nails done. Again, they're detoxing and they're sad and they're depressed, and they have the right for that bed as well. They have the right to the bed. I have no complaints about letting anybody in who's asking for help. I don't want anybody to die. But the next person that comes in is psychotic, and the dream center drops her off and she just wants medication. She hasn't been on her medication. She's been homeless. And then they like took all of her stuff because again, they're cleaning up the, that area. So they take her to the Dream Center. She comes in, the nice people from the Dream Center bring her in. But because she can't say that she's suicidal, and again, obviously she's homeless, obviously she can't, but because she's not suicidal or homicidal, she's let out to the streets with no ride, and she lays on her bench until 7 a.m. Because again, we called Mercy Care 3 times to come and pick her up to take her back to the Dream Center. She's crying. She can't get medicine. She got no help. She's been awake all night now. And at 7 a.m., we released her at 11:50. At 7 a.m., her ride came. She laid out on the bench the whole night. And she was super psychotic, delusional. She thought she had bed bugs. She thought she had lice. She thought that, again, it's just making me sick. That's why I can't, I'm doing intake because I want to learn where the mess up is, but it's.
Well, I will say that in California, the hospitals cannot be touched when they do stuff like that.
Yeah.
We have no recourse as families whatsoever.
Whoops.
Yeah.
I got a daughter with autism who's wandering around, so if you hear in the background.
So Joel, you're welcome to stay on. I'm sure we've overstayed what we asked for. But sometimes we found from providers that they find it helpful when they hear the family stories that they may not hear about, because even as Chuck, as an ER doc and a trauma, they see them and then they don't see them, and they don't always see what happens after. And unfortunately, we see too much, so many tragic outcomes, as Crystal experienced and is continuing to experience in the jail system.